We're just having a panel discussion with all of you. So if you all have slides, put them on. But we're going to have a panel discussion, and we have a few topics to discuss. I thank you, Joyce, for that wonderful introduction. This has been a wonderful international collaboration, and I hope we see a lot more of this. And thank Neuro-opht and all of you. So first of all, in China, neuro-ophthalmologists take the leading role in LHON patient education and management. And the question for the rest of us, therefore, is what's our best practice in collaboration with specialists in patient screening, referral, education, and follow-ups? So we have a small group who spoke, and I'll open it to anyone who wants to unmute and start talking about that. Now, why don't we pick it by country? How about in the US?
Well, I think everybody who was speaking on this summarized it very well. I think that the front line often are not specialists in LHON, and so we need to make sure we get the word out to ophthalmologists, neurologists, optometrists that this entity exists. And if they're not comfortable making the diagnosis, contact your local neuro-ophthalmologist. And I think neuro-ophthalmologists are pretty aware of the disorder.
I would agree.
And Mark?
Yeah, go ahead, Brent.
Yep. I was just going to add that there's now also a network of mitochondrial disease centers around the country that patients should know about and maybe have a consultation there as well, and that all of us, including our ophthalmologists, should be aware of that and be willing to send our patients to these centers, even if they're not necessarily nearby.
Right. How about from Argentina? I think we heard a similar approach.
Well, in our country, there aren't a lot of ophthalmologists prepared to identify rapidly these patients, but we are working to reach better diagnosis. We have so great neuro-ophthalmologists which are working with us and with patients, but the fight is almost mainly in the patient associations. Then we are taking advantage to reach all we need for patients to obtain the genetic test and the correct clinical diagnosis.
Thank you. How about Satoshi in Japan?
Well, as far as treatment concerns, we are unfortunate. We are far behind genetic treatment. And also, as you see, we see newly diagnosed patients 1 to 2 per year. So that right. If some tertiary hospitals are interested in genetic analysis, probably ask the local ophthalmologist to send their patient who is suspected of labors. But without this enthusiasm of the tertiary hospitals, as Japanese ophthalmologists recognize, there is no specific treatment for labors. Just ask the social workers and using some visually aids. So that's all the general ophthalmologist has done here in Japan. And if the tertiary hospitals, such as our university hospitals, are pretty much interested in these academic things, so ask the local ophthalmologist to affiliate it with their hospital, send us some patients for genetic analysis. But as you see, we only done primary 3 main point mutations, and otherwise all other expenses we have to pay ourselves. So full genomic analysis is very hard to perform. So that's our situations.
So interesting, in China, we just heard from Dr. Yu about a 30-minute test to look for the 3 major mutations. So Dr. Yu, is that going to become available? Is it going to be reasonably priced? Is it something that the rest of us...
Recently, yeah. So we can quickly screen the patients, but only 3 mutations. Besides these 3, we need to do further tests. So some patients have family history and they already know their brother or their family member had the similar mutation. Then we can confirm. Otherwise, we need to test full screen.
I want to ask everybody in neuro-ophthalmology a question about patients come to me and say, I can't believe that I went through an MRI, I went through steroids, I went through all these things until I was diagnosed, particularly with people without a family history. Is there something that says that we should, it's almost universal that they've gone through this, has been my experience. Is there something that we should do to get right to the genetic testing when we suspect it and somehow make this diagnosis a lot earlier? So I open it up to all the neuro-ophthalmologists here.
I think the reality is that everyone probably deserves an MRI anyway. Okay, I think you would not want to miss something else, and I think that's a reasonable non-invasive test. But yes, I would love the ability to have a 30-minute test and have the answer. But I would still say that they're going to need imaging. It's not like real men don't eat quiche, right? They're gonna. We all need to do that.
How about steroids, though?
Yeah, I agree with that. But the problem is that Leber's hereditary optic neuropathy is actually a hereditary disease, but an acute optic neuritis variant. And as you know, MRI shows up some enlarged optic chiasm, which is very difficult for us to differentiate it from AQP4 optic neuritis. So at the end, a steroid may be necessary to treat these AQP4 antibody optic neuritis, even if Leber's hereditary optic neuropathy show up these enlarged swollen optic chiasm. So to get some result from the AQP4 analysis, we have to wait for 2 or 3 weeks. And the LHON's hereditary optic neuropathy, if that analysis is done in a short period of time, that is very helpful, I think. So in either case, we have to do all these things.
Yeah, I think for the general practitioners out there, first of all, those findings are usually pretty subtle. Don't you agree, Satoshi? I mean, and they're not that frequent. They're probably in about less than 14% of cases will have it, and it's more a hyper T2 swelling of the chiasm and ever so slight enhancement. Whereas with echoporin 4 neuromyelitis optica, it lights up like a Christmas tree. So I think there's a little bit of difference, but the reality is that journey that people go through, I'm not sure, no matter how fast you get them to a neuro-ophthalmologist, that you're going to cut out some of that journey. And getting the mutation results quickly would help, of course.
Yes, that's right. And interestingly, as for this optic chiasm enlargement or swelling in Leber's hereditary optic neuropathy patients, we have a Professor Imaji, late Professor Imaji. He did all craniotomy to exercise the optic chiasm, the decompression of optic chiasm. We have a long history. So people, Japanese ophthalmologists, are pretty much interested in that kind of thing. Yeah. So we have some bias.
The arachnoid adhesions around the chiasm, when you say you only see 1 or 2 Lebers a year, I mean, the earliest, most extensive work on the description of this disease after Vancinus in the Netherlands was all in Japan. Your legacy of the descriptions of 11778 patients is quite notable.
Well, we have a long history, especially due to late Professor Imachi. He did a very good work on this subject.
So let's move on to the second question about how do we interact with the patient society in LHON patient management. For me, I don't think I have any patient that has not gone to LHON.org or probably spoken to Lissa.
So I have a very interesting perspective on that I would like to share with anybody who is listening from countries that don't have a Lissa Poinçonneau or an organization like what she set up. And that is, when I first started my career and looking at these patients, there was no such thing. And there were and are HIPAA laws, which meant that if you tried to do a clinical trial or tried to get patients, you could only contact patients with whom you had a doctor-patient relationship. You were not allowed to reach out to people that you didn't know. You could reach out to their physicians, their doctors, who could then ask them if they give them my number and they could contact. What Lissa did and what people are doing all around the world now has absolutely revolutionized the involvement of patient advocacy groups and patients in research and in clinical trials. And without that, and I assume the same is in China, it must be, to get that many patients, you must have had some link to the patient groups, because we had, for the GenSight studies, we had over 200 patients total. And there's no way we would have been able to have that many patients enrolled in a year and a half if there hadn't been LHON.org.
Can I say something?
Sure, absolutely, Dr. Yu. Sure.
Yeah. So in our hospital, I would say in our hospital, not in our country, we built a bank of patients with inherited eye diseases. Because I mentioned before, we registered the patients not only for LHON patients, for all the inherited eye disease patients. We this patient bank, the bank of patients, we maintain good communication and contact with these patients, helping them with follow-up visits and health consultations. And once the clinical trial is available, we can quick screen the suitable patients. So I think the bank of the patients is quite important.
So Lissa, do you have any recommendations for us on this question?
I would just say that in every country, the more patients can communicate, the better, because one piece of the puzzle is having people quickly available when there's a clinical trial, but there's also everything else that comes with it. Patients get social service support, patients get guided to information about how to manage their lives with vision loss, but LH1 is different. It's just different. Other inherited diseases, it's a gradual process, or it's something that onset in childhood. So even when people are connected with other vision loss supports and communities, they don't get it. We're talking different languages. And so what happens with the patient community is we can connect, someone who's in their 30s and mid-career with other people who are same age, mid-career, and their issues, they can connect and talk about it. Or we have people that are in, parents, moms of somebody that's in, high school. How do they get through that? And their issues are very different. And it's sudden onset. You don't have time for the school to figure it out. So the patients tell each other what they've done, how they've done it, and provide really targeted, crucial support. So I understand the importance and the power that brought people into various clinical trials. And even when there aren't clinical trials, everything you can do to encourage your patients to work together, because either somebody needs the support and doesn't realize it, but they do. There's things they can learn, or they've learned things that they can share with others. So the more you can encourage and build those relationships, I think the more powerful it is for the community.
Very
I
good.
think
Thank
one
you.
of the best things that Lisa has done is to inspire others to build on the amazing progress that she's made. So I recently had a pleasure of meeting Carmen Subek at Rare X. And for those of you who don't know already, they now have a platform. So, basically patients can sign up themselves and physicians can potentially, sign up to get the database. And I really think that, LHON is really kind of the leader, and there may be other inherited optic neuropathies or other diseases that can also take advantage of this kind of effort. So really excited about that.
So you brought us into the third issue that's on the slide. Are there any databases that can be shared among neuro-ophthalmologists? Nancy's already spoken about privacy laws. And I think that the patient support groups really can do this without that issue that we physicians have. But is there anything more that we should be doing for these databases across the world?
Well, what I learned from Carmen Subek is that it really helps to have a face for the disease. And so, whether it's LHON or something else, essentially the way that they prefer to operate is to support a very active patient, either as a group or a single leader, and essentially provide them with resources in order to promote and educate. And I think for the people for the physicians, coming from my perspective, what we really want is to support them to build a platform that is independent of any particular university, so that the data isn't owned by any single one person, and then able to be potentially leveraged for future clinical trials and as a whole. And so I haven't taken the step yet, but essentially for optic neuropathies, for example, it really, we have to find a spokesperson if they don't already exist. So we need to clone more Lisas.
Let's go to the fourth thing, because we're short on time. Neuro-opht has asked us to think about what kind of LHON patient are more likely to respond well to gene therapy than others. Do we have thoughts on that? I think we've had some results from early clinical trials that give us a little bit of a hint, but what do you all think?
I would love to see the Chinese data published. I mean, really all the details, because I think we could learn a lot from that. I know it's been presented at the AAO, and we'd love some of the slides that you have. I would love more of the specifics on it. I know from the GenSight studies that there were two surprising results. One was that the second eye seems to also respond, which is what you also have reported in the China studies. And I think there are enough studies out there of the natural history that we can cautiously say that it really doesn't seem that it's all because we just didn't get the natural history right. I think the gene therapy is doing something. The second surprising thing is that the people who were injected within the first 6 months from onset didn't do as well, their eyes, as the people who were injected from 6 to 12 months after vision loss. And that intuitively is bothersome. I'd love to hear from the China group whether they've had that finding as well. There's been some hand waving out of Valerio Corelli's group in Italy for a while. He said, well, maybe it's that the axons in the nerve fiber layer acutely are swollen, so the transfection is blocked early on, and then it can get through. But I don't think he believes that anymore. And so we really don't have very good understanding of why that's the case either. So I'd love to hear is that's what's being said, because if you're going to put a trial together, maybe we should be treating these people later instead of the intuitive thing, which is to jump in there as absolutely early as we possibly can.
Nancy, maybe I can quickly respond to your comments question. So first of all, I think as I mentioned, so the phase 3 study is ongoing in China. with the completed sham control group. With a total of 85 patients. The patient enrollment has finished in February this year. So we are expecting.
So Luke, when you say sham control, are you using the other eye as the internal control, or do you mean you have patients who you have done both eyes sham versus patients who have had both eyes or one eye injected?
So first of all, the intervention. So sorry. So first of all, the intervention group.
Only one.
Yeah.
Eye
For the intervention group, patient only received injection in one of the eyes.
Okay.
And we have a sham control group where patients don't receive any injection. They get only a poke in the eye. So this is the protocol aligned with the China NMPA for phase 1, 2, and 3. And also the same for the phase 1/2 study ongoing in the US that's aligned with FDA as well. So the result will come out mid next year. We'll be very happy to share with you at that time. Number one. Number two.
And that's Luke. That's the 11778 patients, or the ND1.
The ND4, the 11778.
Okay.
And also, number two is to, I think a very interesting point you raised. So the patients with the disease onset below 6 months are not recruited in the study, because it's just our observation that the patients are still experiencing vision decline, and they're not being stabilized. It might not be the best time to intervene. So I mean that's part of the reason why they're not recruited. So basically, patients, one of the inclusion criteria is patients have to have disease onset 6 months, 6 months, and up to 10 years.
That chronic. You're doing patients that chronic. And how old are you allowing the patients to be? Because as you know, the prognosis for recovery in patients who are probably 12 and under, but certainly 10 and under, is way better than patients who are 15 and older.
Right now, the patient age is from 12 to 75.
What do you mean 18. By child?
18 to 75.
Yeah.
Well, Joyce, you're talking about the U.S. study coming up, Joyce, right?
Yeah.
Oh, sorry.
No, I'm talking about his study. Yeah.
Okay. Unfortunately, this is not shared today, but we can definitely share this information offline with you.
But you're including children, is what you're saying.
Right. Yeah. 12. Yeah. Up. Since 12, from 12 years old. So again, this kind of patient inclusion criteria was based on the subgroup analysis of those the 186 patients in the 3 IITs. So including their disease onset and also their ages.
Okay, well, I think we're short of a time here, and we should just summarize things. Unless anyone has anything crucial to say right now in our discussion, I'll try to sum up. We've heard of the exciting news about what's going on at Neuro-Ophthalmologists. We've heard about the nuances of the different ways to approach LHON in 4 different countries around the world. And it's a wonderful thing that we've done that. We've heard about the important role of the patient support and advocacy groups. And I think from Lisa, we really heard something very important, that was, in addition to taking care of these patients, to give them a realistic expectation of what's going to be happening to them in this first year, and how it's different than other blinding diseases. I think that was very important. We heard about having laws by the governments and by the international governing societies to support and help people with rare diseases, including those with LHON. And so it's really a collaboration between the patient, the neuro-ophthalmologist, the patient support group, the industry who's developing the therapies, and the governments that are involved. We heard about the importance of counseling, which is extremely important, and the inclusion of the mitochondrial global societies, not just the LHON. I think that it's a very exciting time for LHON. Gene therapy is moving forward, but as we know, not everybody with gene therapy gets better, and some don't get better at all. And I think we're going to have a multifactorial approach. Satoshi mentioned one, that they're being studied in Japan, but we're going to need ways of improving mitochondrial function besides gene therapy. We're going to need gene therapy to get into the mitochondria and not just use the allotopic way of doing it. And we're going to need other things to help vision besides gene therapy itself. So I think it's an extremely exciting time. I'm extremely happy to be involved in the upcoming studies with all of you. And I think this has been a wonderful international dialogue, which we do not see so frequently, and I think we should be doing a lot more of. So I thank Luke and everyone at Neuro-Ophthalmologists and all the neuro-ophthalmologists and Lissa and everyone else here today. So thank you very much and have a wonderful night and weekend. And morning, sorry.
Thank you very much.
Thanks, everyone.
Thank you all.
Bye-bye.
Thank you.
Bye.
Bye, everybody.